And this is our agenda. Apart from the plain chest X-ray, echocardiography remains the most frequently performed cardiac imaging investigation. But it has the advantage of being without radiation. From one echocardiographic study, we have not only anatomical information, but also we can know hemodynamics in the form of chamber pressures, pulmonary artery pressures, and etc. There is a golden rule which we should all know, that echocardiographic examination should be started by our clinical examination. That's to say that the stethoscope should be before the probe. You have to auscultate the patient, you have to take some history from the patient, and then you start your echocardiographic examination. Thanks to Professor Edler, who was considered to be the father of echocardiography. He started his first description of M mode in 1953, together with Professor Hertz. Other cardiologists all over the world continued to have Doppler, to have 2D, to have transesophageal echo, to have contrast echocardiography, and stress echocardiography. Echocardiography started only by M mode, and then we were having the 2D, and now we are having the 4D. Echocardiography uses sound waves to image tissues of different densities within the body. Sound waves travel at different speeds through the materials, having different acoustic densities. To obtain cardiac images, we use ultrasound waves that range in frequency from 2 to 12 MHz. Sound waves with low frequency have deeper tissue penetration, but lower image resolution. On the other hand, the high frequency, they have less tissue penetration, but a higher image resolution. So resolution of images improves with frequency. That's why in adults we usually image with using transducers from 2 to 4 MHz because we need more penetration. On the other hand, the pediatric patients are imaged using higher frequencies because we don't need the penetration, but we need the resolution. The standard modes of echocardiography are the M mode, the 2D, the Doppler echocardiography, and the color Doppler echocardiography. M mode pulses a narrow ultrasound beam in only one single plane through the heart, producing images of the tissue in that plane with a very high temporal and spatial resolution. The M mode or the motion mode is used clinically for the assessment of the valve motion, chamber sizes, aortic root size, wall thickness, and ventricular function. Two-dimensional echocardiography, or the 2D image, produces an arc of ultrasound beams, not a single one like the M mode, from the single transducer head to create images of cross-sectional views of the heart, and we're going to say about the views later on. We have to know that the majority of cardiac images are observed in this modality. This is the basic unit of all other modalities coming, the 2D. This is what we say, the two-dimensional echocardiography. We see the heart moving, we see muscle, we see valves, we see chambers, and so on. And now we come to our basic echocardiographic views, by the transthoracic. As echocardiographic examination is one of the most operator-dependent investigation, and according to your report, many crucial decisions will be taken. Please be accurate. Repeat yourself once and twice, and if you're not sure, repeat again for the patient's sake. As we can see, we start by the parasternal views. It's from the third space, second space. There is nothing like the Holy Quran or Injil. You have to do it when you see the best view in the patient. And if you don't see properly, let him lie on his left lateral position so that you can gain a proper view. This is the parasternal long axis view, where we can see here that this is the aorta, this is the left atrium, this is the right ventricle, and this is the left ventricle. Here is the mitral valve, this is the anterior mitral leaflet, posterior mitral leaflet, and the mitral subvalvular apparatus. This is the aortic valve, have to make sure that we can see here that the posterior aortic wall is in continuity with the anterior mitral leaflet. We are having, the cut is not tilted, and we are having clear cuts. This is the right ventricular inflow view where we tilt our transducer. This is the right ventricle, the right atrium, and the tricuspid valve in between. And you can see properly here that this is the coronary sinus. If we rotate the probe 90 degrees, we get the short axis. This is a diagram of the left ventricle in the parasternal short axis views, where the left ventricle is divided into 17 segments. From 1 to 6, these are the basal segments. From 7 to 12, these are the mid segments. And from 13 to 17, these are the apical segments. And each one is having its own name. This is the parasternal short axis view at the level of the mitral valve, which means the basal part of the LV. As you can see here, this is the sector is like a triangle. The apex upwards where our probe is. Anterior to it is the right ventricle because this is the anterior structure. And then in a circular way, it is the LV. Be sure that you have a proper good circle to comment on the segments, to comment on globally on the left ventricular functions. And then to display the M mode, to have proper measurements for the septum, for the posterior wall, as well if you want to measure by planimetry the mitral valve area, to comment on the commissures of the mitral valve. It's all done through this view. This is at the level of the papillary muscles again, right ventricle anterior as a crescent, and the left ventricle can be seen easily at this level, where we can comment on, in each level we comment on the segmental wall motion, and we have to make sure that we don't see the mitral, we only see the papillary muscles at this level. And finally, these are the apical segments. In this apical part of the left ventricle, again we comment on each segment alone, and then be sure that the right ventricle is a crescent anterior to the LV. And finally, for the parasternal short axis cuts, this is the level of the aorta left atrium, where we measure the aortic root and the left atrium and the aortic cusp separation and the ratio between the aorta and the left atrium. Not only this, but we comment on the aortic cusps, whether they are bicuspid or tricuspid, the coronary arteries, the relation of the aorta to the pulmonary artery, the pulmonary valve, and if we just clarify the view, we can see the tricuspid valve as well, and the interatrial septum, where we can see, as we can see here, the two atria with the left atrium on the left side, on the right side of the screen, and the right atrium on the left side of the screen. Finally, this is the apical 4-chamber view, and as the name implies, we are shifting the probe to the apex. Whatever the apex is in the 5th, the 8th, whatever the space the apex is, we try to put the probe on the apex and be very precise. And again, if you can't see a proper view, you have to change your hands up and down and outside, inside, so that you get the best view to comment. As you can see here, this is the apical 4-chamber view, and as the name means, we are having 4 chambers: the left ventricle, the left atrium, the right ventricle, and the right atrium. And in this view, again, we comment on the segmental motion of the left ventricle, globally on the left ventricular functions, on the mitral valve leaflets, and whether they are thickened or not, on the mitral flow when we display color. And we don't comment on the interatrial septum, whether we are having a shunt or not, except if we have a T sign, because we might have a false ASD here. Comment on the right ventricular functions, the measurements of the right ventricle, and the TEP-C and the Doppler. This is the apical 5-chamber view. It is the same thing as the previous one, but with the addition of the aorta in the view. This is the 5th chamber. When we tilt our hands anteriorly, we get the aorta, and from this we can just measure, especially by the Doppler, whether pulsed wave or continuous, if you are having gradients, plus the other parameters we mentioned before. By tilting our probe 90 degrees, again in the apex, we're going to have the two-chamber view, and as we can see, this is the left ventricle and the left atrium with the mitral valve leaflets seen. Together with this is the anterior wall and the inferior wall. From here we comment on the segments, and if we're having mitral regurgitation, we have to comment on the mitral regurgitation and search for it in all the views, in all the apical views, whether the 4-chamber, the 2-chamber, because we might have an eccentric view and it won't be seen except in one single view. Maybe it's only in the parasternal long axis. So we have to search for the mitral regurgitation in all the views. And this is, as the name says, apical long axis view. It is the same thing as the parasternal, where we had the aorta, left atrium, and the left ventricle, but we got it from the apical view. Here is the subcostal view, which is not usually done in every patient, but we do it mainly in the pediatric age, and in the adults we use them if we want to comment on the interatrial septum. We want to see the IVC, whether dilated or not. Sometimes you don't have any window in the chest wall, and your only window is in the subcostal view, where it's not only one view, these are cuts of views, of many views to be seen at the level of great vessels, interatrial septum, 4-chamber, everything. I'll just show you the one in the 4-chamber view. This is a subcostal view of the 4-chamber. Again, this is the left ventricle and the left atrium, and because and this is the right ventricle and right atrium, and we can see just small part of the liver tissue anterior to the right side. Here we can comment on the, again, mitral regurgitation, again on the interatrial septum. This is not the best view for the interatrial septum. We have a special view for the interatrial septum. Comment on the interventricular septum, right ventricular functions, and so on. And finally, we have the suprasternal cuts as well. It is usually used in the pediatric group, but still in the adults we use these views for if you're suspecting dissection of the aorta, coarctation of the aorta. If we are searching for atheroma in the aortic arch, can be seen by the transthoracic if we exhaust ourselves a bit. If you're having aortic stenosis, you have to finalize your study by searching for the gradient in the suprasternal approach. It might be even higher than the apical ones. So we have to be sure how to make use of this suprasternal approach. What about Doppler echocardiography? Doppler ultrasound, by the way, this is the name of the inventor of the Doppler, so it's always written in capital letter. The Doppler ultrasound uses the Doppler principle, which determines the velocity of blood within the heart. A frequency shift occurs when the ultrasound waves interact with a moving body. For instance, the RBCs, which usually these are the things we search for, and the frequency increases while going towards the probe. Doppler echocardiography has two kinds of waves, the pulsed wave Doppler and the continuous wave Doppler. In the pulsed wave Doppler, we have only one crystal. It is transmitting and then received. So it is unable to measure high velocities accurately, because if we exceed the Nyquist limit, which means we exceed the level beyond which we cannot receive proper velocities, aliasing happens, turbulence, we cannot see the proper velocity. On the other hand, the continuous wave, we're having two crystals continuously transmit and receiving, and hence they are able to measure high velocities accurately. This is the pulsed wave Doppler recorded from the tips of the mitral leaflet, and you can see mitral wave velocity is made of two waves, the early one, the E wave, and the atrial wave. In the normal candidates, the E is higher than the A. If it is reversed, I mean that the E is shorter than the A, this is the diastolic dysfunction. And if the A wave is absent, then the patient is in atrial fibrillation, so we have to make sure that we always comment on the patient whether he is in a sinus rhythm or he is fibrillating during the study, because you might be the only one who witnessed that the patient is having atrial fibrillation. If we have stenotic valves, I mean we have high velocities, then we cannot continue using the pulsed wave Doppler, but we have to shift to the continuous wave Doppler. And this is the wave, the one just below the baseline. This is the aortic stenosis systolic flow, and the one above the baseline, this is the aortic regurgitation diastolic flow. And using a modified Bernoulli equation, the velocity is used to estimate the chamber pressure and pressure gradients. A continuous wave Doppler is capable of detecting the Doppler shift of very high velocities, but take into consideration it does not localize exactly where along the transmission path the shift occurs. And this is different from the pulsed wave Doppler. But again, something else we have to comment if we do have ectopics, because if we have ectopics, we might have more gradient, and this is going to be in favor of detecting the stenosis of the valve. Again, I'm saying we have to comment on the arrhythmias, not only AF or ectopics, but we can comment on arrhythmias during displaying the continuous wave Doppler or the pulsed wave Doppler. And finally, it's not only the pulsed and the continuous wave Doppler, it's also the color flow Doppler. And I have to remind you that the color flow Doppler made a great breakthrough in the echocardiography. It started in the 1980s, and it was really the most important breakthrough in our diagnosis, which made everything later on much easier. The color flow Doppler mapping plots the Doppler shifts on top of the 2D image to show the direction of flow with respect to the transducer head. If it is towards the transducer, it is in red. If it is away from the transducer, I mean the flow is away from the transducer head, then it is blue. We might have turbulence or aliasing. It's away from the transducer, it is green, and it is yellow if it's towards the transducer. This determines if we have this aliasing or turbulence determines the valvular regurgitation, the valvular stenosis, the intracardiac shunts, or if there is arterial connections. As we can see here, this is the apical four-chamber view. We're having the four chambers, the left ventricle, the left atrium, the right ventricle, and the right atrium, together with the interatrial septum. Be sure, don't say that this is an ASD. This is only a hypermobile interatrial septum, and as we said before, don't comment on the ASD just from the four-chamber view. Look at the mitral valve leaflets. They are thickened, especially the posterior, and we can see that we are having an eccentric jet of the mitral regurgitation towards the left atrial free wall. This is what I say about the color flow Doppler, as you can see. Disturbance of the regurgitation. What are the most common clinical applications of echocardiography? It is used in the assessment of left ventricular systolic function, left ventricular diastolic function, valvular heart disease, heart muscle disease by all its kinds, assessment of the pericardial disease, coronary heart disease, assessment of structural heart disease, cardiac masses and tumors, and finally, and most importantly, to guide cardiac interventions. What about assessment of the left ventricular systolic function? It can be done by several methods. The first of all, and the first thing we used to do was the M mode. We put the cursor at the middle part at the level of the muscles, and we measure the posterior wall, interventricular septum, and then we measure the interventricular dimensions, and the diastolic dimension and the end-systolic dimension. We just feed them in the machine, and you're having automatically the ejection fraction calculated. But be sure you have to have a very proper cut. You have to have a good circle with good functions. If you have paradoxical septal motion, I mean they are not going hand in hand, the posterior wall and the septum, then this is not the best way to measure your ejection fraction. It might be by eyeballing, and if you're having segmental motion abnormalities, then do it by Simpson rule. You measure the volumes, the end diastolic volume and the end diastolic volume, both in the four-chamber and the two-chamber view. you give them these data to your machine, and automatically the ejection fraction will be calculated. This helps you to avoid segmental motion abnormality. If one of the segments is not moving properly, then you can measure it and trace it properly. This is the 4-chamber view of a 3-year-old child who presented with dyspnea and hepatomegaly. And when echocardiography was done, as you can see, there's a huge mass taking almost more than 80% of the right ventricular cavity, compressing the left ventricular cavity as well. And from here we can just do MRI to know for tissue characterization and see what's going on. This patient, which proved to be a fibroma. This is the long axis parasternal view of a patient with history of rheumatic heart disease, where we can see that the posterior mitral leaflet is ankylosed, restricted motion of the anterior mitral leaflet, marked dilatation of the left atrium. The aortic valve cusps are normal. Apparently, the left ventricular functions are normal. We could not comment on the calcification of the mitral valve because the gains were not decreased to their minimum, so that we can see just only the calcification. So I cannot comment from here on the calcification. The subvalvular apparatus was not inspected properly. Again, I cannot say whether this is a grade 2 or grade 3, but from the beginning I can just say it is thickened subvalvular apparatus and the thickness of the AV valve. From here, this is the same patient with a 4-chamber view. As you can see from here, the ankylosed posterior leaflet in of the mitral valve, the restricted motion of the anterior mitral leaflet, the markedly dilated both atria, the right and the left atrium, the dilated RV with impaired functions. And on the left side of the screen, you can see here that we are having, yes, there was a defect in the interatrial septum, but as I mentioned, we could not comment on it. But after displaying the color flow Doppler, it was very well seen that there is a shunt across this interatrial communication. We are having severe tricuspid regurgitation, as we can see. I cannot see except a tiny mitral regurgitation on displaying the color flow Doppler. This is another case of valvular heart disease. This is panel A. This is the long axis parasternal view. As you can see, again, this is a thickened rheumatic affected mitral valve, ankylosed posterior mitral leaflet, markedly restricted anterior mitral leaflet motion, hugely dilated left atrium, and there is paradoxical septal motion. There is heavy spontaneous echo contrast in the left atrium. What we are concerned with again is that there is a organized thrombus in the lateral wall of the left atrium. This patient, misfortunately, she was insisting on refusing surgery. That's why we were following her up. This is not the usual scenario for treatment. Panel B, this is the short axis view at the level of the mitral valve. Again, thickened mitral valve leaflets, and it looks severe and tightly stenosed mitral stenosis. The right ventricle is markedly dilated, compressing the left ventricular cavity. Panel C, this is a short axis view at the level of the aorta, tricuspid aortic valve, markedly dilated right atrium. Left atrium is dilated and the interatrial septum is bulging towards the right, meaning that the right atrial pressure is high. Again, the thrombus seen from different views, organized with heavy spontaneous echo contrast in the left atrium. The same patient, but the apical cuts. This is the apical 4-chamber view. Let's look at panel A. This is the left ventricle. The two atria are hugely dilated, as we can see. The left atrium shows heavy spontaneous echo contrast, and the left atrial free wall, we can see the organized thrombus over there from this cut as well. The ankylosed posterior leaflet, markedly restricted anterior mitral leaflet. There is paradoxical septal motion of the left of the septum. Let's look at the right side. Dilated right ventricle. Even by eyeballing, you can see it's larger than the left ventricle. Impaired RV function. And again, the interatrial septum is bulging towards the right side. In panel B, it's the same thing again, with the heavy spontaneous echo contrast in the left atrium. Let's look after displaying the color in panel C. Severe tricuspid incompetence with an eccentric jet towards the interatrial septum, and there is turbulence and aliasing across the mitral valve flow. What about panel D? This is the longitudinal cut of the inferior vena cava, which is dilated. It's more than 2.1 centimeter. It is non-compressible with respiration, with heavy spontaneous echo contrast in it, which looks like there is impairment of stasis of blood in the IVC. This is a case of a male patient who had a family history of sudden cardiac death. As we can see here, the asymmetrical septal hypertrophy. The septum is 1.8 centimeters, while the posterior wall was 1.3 centimeters, and there was systolic anterior motion of the anterior mitral leaflet plus chordal SAM as well. This is the apical long axis view of the same patient with obstructive hypertrophic cardiomyopathy. The pressure gradient across the LVOT was 103 millimeters mercury, and on displaying the color, you can see eccentric mitral regurgitation, severe eccentric mitral regurgitation, where I'm just mentioning, please beware not to contaminate the LVOT gradient with the mitral flow, or else we're going to have we are not going to be accurate anyhow. There is SAM and there is chordal SAM as well. This is a case of massive pericardial effusion surrounding all the cardiac chambers. This occurred post-viral infection, and as you can see, there is a right ventricular and right atrial diastolic collapse. What about echocardiography report? How can I write a report? The echocardiographic report should fulfill all these items: the left ventricular dimensions and systolic function, the diastolic function, the left atrial size, the segmental roll motion if present. If not, we say normal resting segmental roll motion, right ventricular morphology and flow, AV valve morphology and flow, right-sided structure, tricuspid valve morphology and flow, pulmonary valve morphology and flow, the pericardium and masses, if any. There was many advances in the echocardiography. We had the administration of the transesophageal echocardiography, the stress echo, the 4D echocardiography, the strain rate, speckle tracking, and contrast echocardiography. The rationale of having transesophageal echocardiography was to overcome the obstacles found by the transthoracic echocardiography. I mean the deformed bony cage, or if there is a post-operative, the cage is deformed, emphysematous chest, obese patient, breast tissue. This makes it difficult for the operator to have good views. But with doing a transesophageal echo, the probe is in the esophagus and the heart rests directly upon the esophagus, leaving only millimeters that the ultrasound beam has to travel. Are there any contraindications for transesophageal echo? Yes, there are certain absolute contraindications, mainly for esophageal obstruction, stricture or neoplasm, esophageal fistula, laceration or perforation, history of esophageal diverticular, or cervical spine instability. And there are relative contraindications in the form of recent gastroesophageal operation, esophageal varices, upper gastrointestinal bleeding, atlantoaxial disease, severe cervical arthritis, unexplained symptoms of dysphagia or so. Please, before doing a transesophageal echo, take a proper history from the patient for these absolute and relative contraindications. Not only this, but we have to ask for history of renal impairment and history of hepatic impairment, because we give medications that might be hepatotoxic, or the patient, if he's having COPD and we give him sedation, he might go into apnea. So we have to take a very good history so we don't give medications which harms the patient. We do transesophageal echo mainly to visualize posterior structures which are not seen properly by the transthoracic. One of them is the left atrial appendage. Especially in the adult group, it is very difficult to visualize the left atrial appendage. But it should be seen properly and be sure of it that it is free. For instance, before cardioversion, or the patient were having a history of stroke, and we want to know that this is not the source of embolization. And prior to mitral valve valvuloplasty, or else the patient might have embolic manifestations on table. Something else still to see masses. For instance, this patient was having an ICG lead crossing the tricuspid valve, and the patient came presenting with high-grade fever. And as we can see, this was a big mass, more than 1 centimeter, highly mobile on the lead of the pacemaker. Again, masses and masses. This patient was 40 years old, presented with a dyspnea, and as you can see, this is a case of Epstein anomaly, displaced tricuspid valve, significantly displaced, small right ventricular cavity. Not only this, but there was a big thrombus in the right atrial cavity, and the patient was present, and the dyspnea was due to repeated showers of pulmonary emboli. Not only this, he was having massive anterior pericardial effusion, which was also surrounding the rest of the cardiac chambers, but it was mainly anterior. Again, one of the indications of the transesophageal echocardiography is to exclude the aortic dissection. And as you can see here, this is a cut in the zero level where we can see the circle of the descending aorta, and there is a flap inside the circle. The small cavity, strange enough, this is for the true lumen, and the big cavity where we're having spontaneous echo contrast, this is for the false lumen. Again, this patient was having, this is at the level of 90 transesophageal echo. This is the SVC, and there is a shunt of flow between the interatrial septum and the SVC and the SVC. This is a case of sinus venosus ASD. This is another case of ASD. This is a primum ASD in a very old man. He presented in his late 70s and was the first time to be discovered. The lower part of the interatrial septum was absent. We not only just visualize the interatrial septum alone, but in ASDs we have to visualize the pulmonary veins as well, and this can be easily done by the transesophageal. This is the third type of ASD. This is the central secundum ASD. This is the short axis at the level of 45. We can see the circle of the aorta. This is the interatrial septum, and this is a secundum ASD, which was amenable for closure. In most centers, transesophageal echo remains the imaging technique of choice for precise assessment of mechanism and severity of valvular heart disease and their associated complications. Not only this, the interatrial septum is also importantly can be seen properly by transesophageal. In the adult group, more than 20% of cases of ASDs can be missed by transthoracic echo. In this patient, we were in doubt of having ASD because the right side was dilated, but we could never see that it was a fenestrated interatrial septum with multiple defects across the interatrial septum, which definitely will change our decision whether to close with the device or not. And we have to measure and see whether we're having a bigger ASD or what. We are going to change our total decision for this patient. We have different cardiac imaging modalities. On top of the list is the echocardiography, the nuclear cardiology, the cardiac magnetic resonance imaging, and the cardiovascular computed tomography. These techniques are often used together for a multimodality comprehensive assessment of a number of cardiac diseases. The beginning of the 21st century in cardiovascular imaging has been dominated by one theme, which is the multimodality. We use many things to get a comprehensive diagnosis. Each of these techniques has strengths and weaknesses, and in combination they are used widely in the management of patients with valvular heart disease, heart failure, congenital heart disease, arrhythmias, and even coronary heart disease. The echocardiography has many merits among other cardiac imaging modalities. It is the most available, it's less costly, it has no ionizing radiation. It's a good tool for assessment of systolic and diastolic functions. Assessment of valvular function, it is the first, and it has no contraindication. It is not affected by renal failure or claustrophobia or something like this. But when we want to examine extracardiac anatomy or the coronary artery assessment, this is better done by the CT and the MRI over the echocardiography. The echocardiography is very beneficial, being safe, relatively cheap, can be repeated, and it can be done bedside. What about stress echocardiography? It has progressed significantly over the past 3 decades to become one of the most widely utilized imaging techniques for evaluation of patients with known or suspected coronary artery disease. It became that common because of the availability of the echocardiographic machines, lack of exposure to ionizing radiation, being safe, and it can be done physiologically by treadmill or bicycle, or pharmacologically by inotropes or vasodilators. And of course, it is portable. And the option of performing physiological stress is important, as this should always be preferred stress technique in an attempt to reproduce the patient's symptoms and also determine their functional aerobic capacity. Stress echocardiography is not only performed in those with ischemic heart disease, but also there are other indications. For instance, the non-coronary applications might include those with valvular heart disease. In the case of asymptomatic severe aortic stenosis, when you do an exercise, this exercise might induce changes in mean transaortic gradient, might increase significantly, and also the pulmonary artery pressure might increase significantly. This means that the patient is having a severe aortic stenosis and he needs intervention. Also, the heart muscle disease, it's the same thing. The exercise might induce dynamic left ventricular outflow tract obstruction in cases of FOCM, or we should measure the contractile reserve in response to low dose dobutamine in those with dilated cardiomyopathy. And assessment of viability in ischemic patients. This is very important. For instance, this patient with moderate mitral stenosis, but he had severe symptoms in the form of dyspnea, and he underwent exercise stress echo. At rest, his mean transmitral gradient was 5 mm mercury, and the tricuspid pressure gradient was 24 mm mercury. After 7 minutes of Bruce protocol, the mean pressure gradient increased up to 27. Can you see, from 5 to 27? And the tricuspid valve pressure gradient increased to 51 mm mercury. This means it was a significant mitral stenosis. So the patient underwent balloon mitral valvuloplasty with excellent symptomatic relief. This is another case of a 47-year-old man with hypertrophic cardiomyopathy who underwent exercise echo to be sure of the severity and how obstructive his condition is. At rest, the peak gradient across the aortic valve was 12 millimeters mercury. After repeating assessment during a held Valsalva maneuver, the peak gradient increased to 63 millimeters mercury, which indicates that the exercise might induce more and more obstruction. At peak stress, the maximum gradient increased from 12 to 135 millimeters mercury. Note here that there is a late systolic peaking of the Doppler profile in B and C, which indicates dynamic rather than fixed outflow tract obstruction. The patient was started beta blockers and his symptoms improved. But I just want to tell you something. Please, while doing this and while measuring the gradient across the LVOT, beware of contamination of this flow with the mitral regurgitation flow, because if this happens, you might accuse a patient of being obstructive and actually he's not. Three-dimensional echocardiography or four-dimensional echocardiography is considered to be something new, but actually the idea started maybe more than 30 years ago. But the breakthrough was after the introduction of the color flow Doppler. Not only this, the technical advances which made the size of the transducer smaller and improvement of the speed of imaging processing had made a difference. And also the real-time 3D imaging made a great difference, made this four-dimensional echocardiography applicable. So the advent of three-dimensional echocardiography represents a real breakthrough in cardiovascular ultrasound. The backbone of current three-dimensional echo is the transducer, because the footprint of the transducer, when it became smaller, became much easier to be used. A conventional 2D transducer is composed of 128 piezoelectric elements arranged in a single. But the modern three-dimensional echocardiography matrix array transducers are composed of about 3,000 individually connected and simultaneously active piezoelectric elements, which are arranged in rows and columns to form a rectangle of grid matrix configuration within the transducer. There are many clinical applications for the three-dimensional echocardiography: the left ventricular morphology and function, right ventricular morphology and function, mitral valve evaluation, tricuspid valve evaluation, and guiding interventional procedures, whether in the cath lab or in the surgical theater. For example, as we can see here, this is the interatrial septum, which we can see by the just 2D as one line. You can see the depth of the interatrial septum, and we can see the tiny fenestrations and the aneurysm of the interatrial septum can be seen here easily. I just want to say before I continue that to have a good 3D image, you have to have a good 2D image, because the 3D is based on the 2D image we're having. So get a good 2D image or else you won't have a good informative 3D. As we all know that there is foreshortening of the left ventricular longitudinal axis is a major cause of volume underestimation by 2D, which accounts for the larger biases observed in comparison with 3D. The results of the recent meta-analysis conducted on 95 studies demonstrated that the 3D image also underestimates the left ventricular volumes compared to the CMR, but still they are compared to each other in the calculation of the ejection fraction. The various methods of display of 3D images are full volume, multiple tomographic slices, surface rendering, and volume rendering. What about the right ventricular morphology and function? Assessment of the right ventricle is really challenging by transthoracic echocardiography because in the anatomy of the right ventricle, it is a complex asymmetrical geometry. We cannot see the whole thing, the inflow, the body, and the outflow in the same time by one view. It is extremely difficult. And it is highly trabeculated endocardial borders. And we are having lack of precise anatomical landmarks which we can rely on. Also, the unfavorable position of the right ventricle in the chest helps that we still find difficulties in assessing of the right ventricle. And misfortunately, any minor changes in our hands or rotation or just tilting the patient, we can change the whole thing and the whole image of the right ventricle. Three-dimensional echocardiography opened a new era in evaluation of the right ventricle. We can obtain all the three parts of the RV in the same dataset with adequate temporal and spatial resolution. There are certain dedicated software packages for the RV mapping and measurements of the RV volumes and function without making any geometrical assumption. 3D analysis of the right ventricular volumes and functions of utmost importance. This figure shows the display of the changes of the right ventricular volume during cardiac cycle. Mitral valve evaluation is very important. The three-dimensional echocardiography contributed a lot in our understanding of the mitral valve structure because of the in-face views we have, which are equivalent to the surgical views to understand the mitral valve and its scallops. So the three-dimensional transesophageal in particular is the most useful imaging modality for the diagnosis of mitral valve diseases and to guide their management. As you can see here, this is in the panel A. You can see the anterior mitral leaflet, the posterior mitral leaflet, left atrium, the left ventricle, and the aorta. On displaying the color, we found an eccentric jet of mitral regurgitation. But we can never know what's the reason of this eccentric jet. When we did the three-dimensional echo and cropping and we had the en-face view of the mitral valve, we found that there is a cleft of the posterior mitral leaflet, which is the source of mitral regurgitation. So the patient was subjected to repair rather than mitral valve replacement. The same thing here, as you can see in the first panel. On displaying the color, we were having mitral regurgitation. Still, we don't know from where it is coming. But when we did the three-dimensional echo, we found that there is, in the posterior mitral leaflet, there is a cleft in it. And the regurgitation is coming from there. And here we can see in the posterior leaflet from both the lower panels. In the cases of mitral valve prolapse, the added value of 3D echocardiography is the possibility to visualize the mitral valve in the beating heart from the same perspective as in the operating room for precise identification and sizing of the prolapsing scallops, assessment of disease severity, and accordingly the surgical plan. As you can see here, this is a case of severe mitral regurgitation. Still, again, it is eccentric mitral regurgitation. And you can see that we're having severe posterior mitral valve prolapse, P1 and P2. And we have to admit that in cases of mitral stenosis, three-dimensional echo has significant incremental value in assessment of the valve. The direct planimetry of the mitral valve area is of utmost importance because it avoids the limitations of the transthoracic echocardiography, mainly in the angle dependence, load dependence, and the influence of the cardiac rhythm and hemodynamics. Also, by three-dimensional echo, we can directly visualize the narrowest part of the valve, and accordingly we measure it, because sometimes you are not sure where you are measuring exactly whether this was the narrowest part or not. As you can see here in panel A, You have 3 cuts, you can do them, and everyone is going to give you a different valve area. But by 4D, we're going to have direct planimetry of the mitral valve area, and you get the narrowest part. What about guiding interventional procedures? Now, it's crucial to have 4-dimensional echocardiography during these procedures, regardless of the type of the intervention you are doing. For instance, if you are doing for closure of defects, at the beginning you re-diagnose properly. You have to remeasure once and twice the defects. You do device sizing, the intra-procedural guidance, whether you are going to put the device properly. You're going to have it, for instance, lying on the mitral valve or on the tricuspid valve or affecting the aortic valve. This is of paramount importance. Also, the post-procedure evaluation of device function and potential complications can be easily evaluated during the percutaneous closure, for instance, of atrial septal defects. 4D echo can be used to assess the location and size of the defect, assess the relation with other cardiac structures, obtain en-face views of the defect from both sides of the atria, assess the device deployment position post-procedure, and display 3D color demonstrating the presence and direction of potential leaks around the device. As you can see here, during the PFO closure of a patient with a cryptogenic stroke, we had the X plane and we were having to see the sheath going through the PFO. And we had displayed the 3D to see the device while being pulled across the defect. Again, you see it from both sides, from the right side and from the left side. And you see the device lying properly and making sure it is not affecting any surroundings, it is not prolapsing, it's not affecting mitral valves or tricuspid valve or anything. Or you're not leaving another defect which was there and you missed. And here, while the device is deployed, you can see it is lying properly on the interatrial septum. Here again, and you see them and you do the bubble test afterwards, and you are sure that your device is well placed across the interatrial septum and no other leaks. What about the TABI? 3-dimensional echocardiography, I mean the transesophageal 3-dimensional, is widely used in patients scheduled for transcatheter aortic valve implantation, for sizing of the aortic annulus, characterization of the periannular regions, I mean the cusp, labyrinthine outflow tract, and proximal part of the aortic root, assessment of the position of the coronary ostrea relative to the valve cusps. During the procedure, the 3-dimensional transesophageal helps in positioning of the catheter and prosthetic valve. After the transcatheter valve deployment, provides a rapid and accurate assessment of the location, function, and coronary paths. Several studies demonstrated that the 3-dimensional transesophageal measurements of annular aortic annulus are accurate and reproducible and correlate well with the reference standard CT. However, still, we have to admit that the first choice is for the CT, and calcification may hinder the visualization. So, still, we have to say that the priority is for the CT in this. What about deformation imaging and myocardial movements? We all know that the myocardial muscle is having a complex orientation of myocardial fibers. We have longitudinal fibers, we have radial fibers, and circumferential fibers, and they all shorten in different ways. To assess this, tissue Doppler imaging and speckle tracking echocardiography are the techniques that permit detailed analysis of regional as well as global cardiac function through the unique temporal and spatial data processing. The tissue Doppler filters out the low amplitude and high frequency signals coming from the blood pool, so to allow analysis of the high amplitude and low frequency signals from the myocardium itself, which we are concerned of to see these fibers under control. In this four-chamber view, we see that the longitudinal strain of the left ventricle showed elongation of the apical segments instead of being shortened. This denotes dyskinesia of these segments, presented here in the curves by the purple and the green color curves. On the contrary to this, longitudinal strain of the LV in the apical four-chamber view in this case showed preserved apical segment longitudinal strain, but reduction of the values of the mid and basal ones. This is characteristic of amyloidosis. The idea of contrast echocardiography is to use contrast agents consisting of gas-filled microspheres which resonate quickly when exposed to an ultrasound wave. Microbubbles are several million times more effective at scattering sound than RBCs, resulting in a greatly enhanced blood pool. The blood pool agents developed consist of a gaseous material encapsulated within a stabilizing outer shell. These microbubbles are typically slightly smaller than the RBCs, allowing free passage within the circulation, so effectively acting as red cell tracers. This is an example of a patient who is having embolic manifestations, and you can see here this is the fourth chamber, the contrast injected, the border is very well delineated as well as the myocardium, and the apex is obliterated. This patient was having an apical thrombus. In general, echocardiography has certain limitations. The greatest advantage of cross-sectional imaging, I mean to use the CMR and the CT over echocardiography, is the information available on extracardiac structures. The aorta, the aortic arch, pulmonary artery, and pulmonary veins are far more clearly seen by these modalities and are often poorly seen or not seen at all by echocardiography. But for instance, the pulmonary veins, at least I see their origin. Thus, assessment of pulmonary veins in patients awaiting an atrial fibrillation ablation procedure, assessment of the aortic arch and descending thoracic aorta in patients with chronic aortic dissection or coarctation, and serial assessment of patients with previous coarctation repair, for example, will be better done by the CMR or the CT. Echocardiography can also suffer from poor imaging quality, despite the use of ultrasound contrast agents, for example. This is most often seen in patients who are extremely underweight or overweight. Not only this, but also in patients with chronic airway disease or chest wall deformities, for example, the pectus excavator. Still, transesophageal echo can overcome such a difficulty. Also, patients in the intensive care units who are frequently supine and may be mechanically ventilated, the transthoracic echo might be challenging. Again, transesophageal echo can solve the problem. Echocardiography permits accurate assessment of myocardial structure, function, and perfusion. But we have to take care now that echocardiography is thus in itself a multimodality imaging technique. Again, as I started, don't forget your stethoscope, please. Thank you very much.